Okay, we're going to go over IV fluids. So we are in we're on page 308 in your book, which also has an excellent chart, table 17-7. And we're just going to talk about IV fluids, then central access devices. You'll find there'll be a lot of different reasons why your patients require IV fluids. Sometimes maintenance, just they're not capable of taking in PO fluids for whatever reason. Maybe they're going to surgery, maybe they've had surgery, maybe they're on gut rest, that they're not able to take enough fluids by mouth. Also, we see IV fluids as replacement when losses have occurred. So someone who's had significant nausea and vomiting and diarrhea, someone who's had a considerable fluid loss, let's say from like a heat stroke, someone who has a loss of electrolytes also. Fluids are actually categorized by tonicity, and this just means the osmotic pressure of the fluid related to the concentration of electrolytes in the fluid. So we just have to make sure we pay attention to this, because when we're correcting water and imbalances, fluid and electrolyte imbalances, we want to make sure that the right fluids are prescribed. They're either going to be hypotonic, isotonic, or hypertonic. Those are the three categories of crystalloid solutions that that your patient can have ordered. This is just a picture. It's showing you cells, and when cells consistently receive hypotonic solutions, and an example of a hypotonic solution that you will find on page 308 is half normal saline. That's the most common hypotonic solution. What happens or potentially could happen to that cell? So hypotonic solutions hydrate the cell, and it shifts fluid from the intravascular space to the intracellular and interstitial space. And if we give too much, they can actually cause the cell to swell and could actually even rupture the cell. And so that's a hypotonic solution. The other thing that you should know about hypotonic solutions, they're more water than electrolytes. Just a few other comments about hypotonic solutions, which I said the best example is half normal saline. These are typically used as a maintenance fluid, and just watch for or monitor for changes in your patient's mental status. All right, isotonic solutions. So again, it's showing you what happens with the cell, and you can see it's essentially unchanged. And this is because it expands only the extracellular fluid. And so there's essentially no net loss or gain of intracellular fluid. It is ideal when we need to replace someone who has an extracellular fluid volume deficit. So if you're looking on page 308, you can see some good examples of isotonic solutions, and these are the ones that you guys are going to see most commonly in the hospital. And the ones that you're going to see are normal saline, so 0.9% normal saline. You're also going to see a lot of lactated ringers. And so the main ones that you're going to see are normal saline and lactated ringers. When you look at normal saline, you can see that it has no glucose content. And when you look at LR, it also has no glucose content. Now, initially, D5W starts off as an isotonic solution, but when it's broken down, it actually becomes hypotonic. And you can also see that it has a significant amount of glucose in each liter. And so often, D5W is not a fluid that you'll see very commonly in clinical situations. Just a little additional information about isotonic fluids. We're looking at the table on page 308. It's a good time to remember that normal saline is the only solution that can be used to administer blood products, and that it does not provide any water, calories, or other electrolytes. When you go down to LR, you can see that it is more useful in the treatment of burns and lower GI tract issues, and that it does it also does not provide any free water or calories. The last type of solution that we're going to talk about is called a hypertonic solution. And again, you can see what's going on here when you have or you give a hypertonic solution. Initially, it'll expand and raise the osmolality of the extracellular fluid, but then it can potentially, because of this, dehydrate or shrink the cell. And so it is useful when someone comes in and they have hypovolemia or hyponatremia, but we have to be extremely careful when we give someone a hypertonic solution, because the probability of fluid overload exists, and so we need to make sure that we monitor for fluid overload. When you guys are looking on page 308, you'll see that there are numerous types of hypertonic solutions. For instance, D10. D10 is not something that's used very commonly in the clinical setting. 3% normal saline, again, is not used very commonly, only if someone would come in with severe hyponatremia. But a couple of things that are considered hypertonic that you will see frequently are D5.5 normal and D5 normal. And those are solutions that you guys will actually see. So we're talking about giving a hypertonic solution and being aware of the fact that you need to monitor for fluid overload. So what are signs of fluid overload? We've already talked about this. What are signs of fluid volume excess? So you want to watch your blood pressure. Is it going up? You want to listen to your lungs. Is your patient developing crackles? Are they gaining weight? Are they putting fluid on? You also want to watch your serum sodium levels. If someone came in and they were experiencing hyponatremia, we need to make sure that we do not overcorrect them. So frequent monitoring of your sodium levels. Okay, last we're going to talk about volume expanders. And now we're on page 309 in your book. Now the difference between plasma volume expanders, which we call colloids, and remember we called the isotonic, hypotonic, and hypertonic solutions, they're crystalloids. Plasma expanders are called colloids. Examples of colloids are listed in your book as well as on this slide. For instance, one not listed here that's commonly given is albumin. It comes in a couple of different concentrations. Dextran, head of starch, and blood are all considered colloids or plasma expanders. They differ because they actually stay in the vascular space and increase osmotic pressure. And so they stay in the vascular space longer than crystalloids. And often this is necessary when someone is suffering from like significant blood loss or fluid loss. The reason they stay in the vascular space and stay there longer is because these guys are actually proteins. So colloids stay in the vascular space, increase osmotic pressure, and they're proteins. Examples would be albumin, dextran, and head of starch. We give these to someone when they have had significant fluid and or blood loss, and we need to increase their blood pressure. So you would want to monitor for effectiveness, but you also need to make sure that we've not gone the other way. So you really have to monitor patients that you give colloids to for fluid overload. And we've already talked about this a couple of times, the signs and symptoms that you would need to monitor for fluid overload.